thewellnesscouch.com, streaming wellness into your lives. Download the app today.
This is Up for a Chat with your hosts, Cyndi O'Meara and Kim Morrison.
Here we are, up for a chat about the hottest topics that are important to you, inspiring you to awaken the change within. I'm Cyndi O'Meara.
And I'm Kim Morrison. What a delight this week to have a very special soul on the program. A highly intelligent being, I might add, Dr. Kieran Richardson, who we just watched 10 minutes try and set up a microphone for the podcast. So I just want you to know, just because you're a doctor doesn't make you a doctor or specialist in AV, apparently. But we've had a ball watching and witnessing this. But let's get serious. This beautiful hot soul is someone who actually knows a lot about the musculoskeletal system. And he is also very passionate about patients undertaking physiotherapy to rehabilitate and solve their pain and injury problems prior to opting for imaging, injections, or surgery. This is a topic right up my alley, and I'm so excited. Welcome to the show, if you so dare, Dr. Kieran.
It's great to be on. Although we had less than auspicious circumstances to start, hopefully it'll improve from here on in.
And how cheeky was she? How cheeky? All right.
Did you say this? Did you say this hot soul? Did you say that?
Or I may have.
Don't objectify me from now on. All right?
Oh, I'm so sorry. Men have been objectifying women for centuries, and here we are. We finally get a chance.
Not all men are pigs. I'm not a pig.
But you are a highly intelligent soul. I'm curious to know, could you take us on a journey, gorgeous Kieran, as to how you got passionate about the human body? I love hearing how people become physios or into the world of musculoskeletal, because to me personally, having studied the body for a number of years, not of course to your degree, but I am so blown away by the complexity, the integrity, the amazing way in which our bodies operate, and also how much we actually don't know. Could you take us on that journey, gorgeous, and let us know what led you into the work you're doing today?
Look, that is a very, very good question. Depends how far back you want to go. I remember having an interest in health. Even I can hear a New Zealand accent. So I actually grew up in New Zealand, and I remember, so I still support the All Blacks, just for the record. I remember having an interest in health even as a youngster. I was just contemplating it the other day. There was one of my friends had a fall and they scratched their arm, and I remember taking them to the sick bay, which is what they call it in New Zealand. And I was trying to get a Band-Aid and put it on them. I just have always found the body, like you, fascinating. And then going through primary school, for some reason, I just did really well in health studies. Like I'd get top of the class. I just found it interesting, and I was very into sports. And so also having sustained quite a few injuries. So it's a sad realization when you're going through your teens and you realize you're not going to become a professional athlete. And some of my injuries I was able to overcome. Some of them were in fact missed by both physiotherapists and doctors. And so I can tell you a bit about that, which I now have had to work through on the other side, which has helped me build, I guess, empathy for patients who have either had long-term issues or maybe the healthcare system's let them down in a way. And then it got to the end of high school and I was considering what I wanted to do with my life and career. And my parents said I always wanted to be a pediatrician. And so I looked into medicine. I looked into physio. I also looked into accounting for some reason, but I did one day of that and got bored. But then I just settled. I went to both open nights, medicine and physio. And the physio one really just, I connected with it because they spoke about how you build this relationship with the patient. So you're not just kind of prescribing. It's actually like a friendship relationship that you build. And so that had always, I guess I was a kind of popular guy and I liked building friendships. And so that was what I chose. And multiple times I've considered doing medicine since, and I never could now. I just think there's so much that we can offer as allied health I don't even like that term, but that's what they call us, non-medical, that's scientific, that can really help patients. So that's where I found myself. Yeah.
So you have a doctorate, or you are a doctor,
Yes.
but we looked on your CV and we couldn't find what you
Yeah.
did to get that. So
Yeah.
we saw your master's, we saw your
Yes.
Bachelor of Science.
Yes.
Are you a doctor of something or a doctor of
Yes.
therapy?
Yes.
Yes.
Yes, I am. So how it works in Australia is you've got a few ways that you can become a doctor of physio. So there's undergraduate uh, doctors of physio that you can get now. You can complete a research and become a new graduate as a doctor. It's like 5-year degree, similar to dentistry or similar to veterinary. You can do a physio degree, you can do a master's, and then do a PhD to become more of that academic pathway. I've done a PhD in the field, in inverted commas, or a postmaster's doctorate fellowship, which is at the Australian College of Physiotherapists. So they confer that title doctor on you when you complete that, which is it makes me an expert clinician. So I've done as much training in the practical clinical skills of helping patients as you can do in the world. And Australia, I don't know what you guys know about physiotherapy, but we probably are the world leaders in various forms of physiotherapy. And so that it's a level 10 postmaster's doctorate fellowship that I've finished. And yeah, so they allow us to use the term doctor like a medical doctor does, but they don't have a PhD, but they can be called a doctor. A vet's the same, dentist the same. It's the same with physio now. Yeah.
The PhD is the real doctor. Really.
Well,
It's the real,
well,
that's what they say. The PhD is the real doctor. Everybody else is an honorary doctor. Is that
yeah,
right?
that's true. That's true. So it's like basically I argue with my wife about that. She's doing a PhD in psychology.
Oh, wow.
Yeah. So she's doing it in parenting strategy, which maybe you could get her on the podcast. So that's very interesting. Yeah. So she's looking at that in early childhood, but that's a whole nother topic. Yeah. So if the children don't quite work out, that if the kids don't work out that we have, I'll blame her basically.
Well, it is always the mother's fault. It's your mother's problem. That's what it is.
I'm not going there.
It was your mother that did that. And that's why you're like that. It's because of your mother. We've always known that.
Okay. All right. I'm not going to argue.
But that's what you hear. All right. I want to know the paradigm of physiotherapy that you were educated with.
Yeah.
And the paradigm that you're with now. And because I think you are very different in the way you approach things. So let's first talk about how were you educated and what was that paradigm?
It's a very good question, Cyndi. So I guess it'd be interesting to look at different healthcare professionals and how things have changed. So I studied in the early 2000s, and at least in musculoskeletal, which is my specialty, so joints, bones, muscles, nerves, it was very mechanistic. I guess the body is a machine. This is wrong, so we're going to do this. It wasn't really like whole person so much. Whereas in my master's, which I finished 13 years ago now, that became more. We were becoming more aware of how research, I guess, can shift, and you see this in different fields where healthcare knowledge will double every 15 to 20 years, probably more rapidly than that now. And so you can get the evidence grows and shifts and becomes better quality. And then we realize there's a lot of things that we used to think which we change. And so like it was cool then, but now we have this different view. And so it's probably the way that I practiced early and what I learned to now has in many ways done an about face. So what I'm encountering and what I tend to see in clinic is there's often the healthcare systems that are still set in place are maybe 20, 30 years old. but how we can help patients is very different. And then obviously technology will be innovated and catch up. And so practically what I'm doing now in my typical weeks is very different from when I graduated. It's totally different, but also the philosophy underpinning it is quite different. So, yeah.
And what is that philosophy underpinning it? If mechanism is the way you were taught, are you looking at a more like holistic or vitalistic?
Absolutely. Absolutely. Yeah, for sure. So, like, I mean, the kind of simple way of looking at it is biopsychosocial, right? So you've got like the biology of the patient, you've got the psychology of the patient, you've got their social circumstances. That's a cursory or superficial way of looking at it. But it's every person's an individual. Every person's a kaleidoscope of challenges and opportunities. And so when I'm looking at a patient, yes, they have their pain. They're pointing to their sore body part, but I'm thinking about what psychologically how this may be impacting upon them. And I guess the goals and what the greater context of their life is and where they're headed and how I can play a part in getting them independent. So that all these things are going through my mind when I'm starting to talk to patients. So it's not just like, what does the scan show? It's like, what is this? How can I reframe this to give them hope and give them meaning and get them out of this bind that they might be in?
I love it. I absolutely love what you're doing, because I think we need to start looking at, not that mechanism is not has its place, but I think we need to do that broader thing. Like, I'm a nutritionist, so I look at not mechanistic nutrition, which is proteins, fats, carbs, minerals, vitamins, things like that. I look very vitalistic like you are, and I look at the whole food, not the butter for just the saturated fat, but the butter for everything else. So it's really exciting to listen to you talk my philosophy, but in physiotherapy. And you know, we're starting to see that even in medicine. We're seeing it in psychology. We're seeing it, like your wife no doubt would know, that what's happening now in psychiatry and psychology is like a whole new revolution.
Yeah.
It's exciting. And I think we needed to go there. I think mechanism has its place.
It does.
But what you're doing is so different. I don't think I've ever heard of a physiotherapy that's doing what you're doing. And I do want to read you something.
Okay.
And this came from the person who told me we should interview you. She said, hope it's a great chat with Kieran. Today I'm out of my brace, 0 degrees, I don't know, or 0 degrees or something. Back hiking, no surgery. I'm running, surfing. I'll be running, surfing and playing tennis again in no time. Telling from me and a huge, big hug of gratitude.
Wow, that's awesome.
So, you know, like she was devastated. She was told there was no other way out. She had to have surgery. There's nothing that she could be done for her. So,
and this is an ACL injury for those listening in. Yeah.
Do you want to explain without saying who it is? Well, I'm going to. Works for me, you know, and I watched her go through I watched her come in from an appointment crying.
I know.
Appointment from other people crying that they said, there's nothing you can do about it. That guy doesn't know what he's talking about. And blah, 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 blah. So help us understand what it's like doing what you're doing and how you're helping her.
Your questions are really good, but like it depends how long you want to go on this podcast for, because these are like it's been a very full on journey in many ways, almost like, I don't know if the listeners or if you guys have watched The Matrix, where like Morpheus presents him with the 2 pills. Yeah. It's like, do you want to take the blue pill and just be how you've always been, or do you want to take the red pill and kind of like see how far the rabbit trail goes? I think like you alluded to it before about the benefits of the mechanistic approach. There is no question. Like, I am not anti-surgical. I am not anti-medical. I've been a part of scientific debates and some of the surgeons try to pin that on me. But I literally start by saying I'm not, and then I'll give the circumstances where I believe the surgery is necessary for ACL tears. But the problem is, in healthcare, especially in westernized countries, the entire system is funds the mechanistic. So I think in many ways it's well-meaning, but the patients is exactly what happened with this one that we're talking about, this case. They don't get presented with their options in a balanced way. It's quite rushed, right? And it's not patient-centered. And the listeners may not know, but there is massive profit drivers. So we're talking the surgeries sometimes can be $5,000 to $10,000 for a 30 to 60-minute operation. And so what we are offering is drastically cheaper, patient empowering. They probably get back quicker. And then the best empirical studies will show essentially no difference across the board between having surgery and doing a rehabilitation program or doing a rehabilitation program. So that's very good news for patients. It's not so good for the mechanistic multi-billion-dollar system that's been set up across the world. And so you do see patients who are starting to question that. And so we started a Facebook group 6 years ago now, because we looked on Facebook, and there was every single other Facebook group was like recovery after surgery, problems after surgery, ACL surgery recovery. And then we thought, you know what, we're going to start a non-surgical one. So we started ACL plus meniscus tear recovery without surgery. And we've now got almost 29,000 members in there. And it's a free group, and it's evidence-based. We even have a surgeon and medical doctors in there. So we're trying to promote this idea that there's options, at least. And so it's been a pretty wild ride for me so I guess, you asked about like my journey. It's probably now we're able to help patients, and since COVID, it's become more acceptable, I guess, for patients to use telehealth and video. And so I was previously, up prior to COVID, probably doing, 4.5 days a week face-to-face, whether it be teaching or giving second opinions. Whereas now I do 3.5 days a week behind a computer giving telehealth to patients all around Australia, but all around the world, because there's this, you can kind of just get straight to the patient wherever they're at. And I guess you kind of bypass a lot of that healthcare, those healthcare mega systems that may not be patient-centered.
I had the privilege of working, I don't know if you know his name, but David Abercrombie, who was the All Black physio for many, many years.
This is going to be absolutely wild.
Why?
I'm not joking you. I grew up next to him. He was my next door neighbor in Auckland, New Zealand. I'm serious. He probably won't remember me because I was about 8 years old.
You probably did come in a few times.
But his son, I'm sure, played basketball.
I think he did, yeah. But he was very well revered, and he kind of thought a little outside the box. He did acupressure and acupuncture as well. And I worked in there as a remedial therapist, and he even didn't mind me bringing in my wacky oils and essential oils. And when John Kerwin, who, for those that don't know, was a famous number 14 All Black, would come in each week and he'd go, "Hey, what's that smelly stuff?" And then he'd take it home to Farella, his beautiful wife. And then that's when David started listening, when one of the All Blacks was actually saying he loved using the oils while he played. But one of the things that David, I would always admire in him, even though he saw a lot of patients each and every day, he seemed to take quite a holistic approach, even though there was a lot of mechanism, and he didn't use a lot of what I used to think and see a lot was a lot of TENS machines, or people just put on a machine and left on a table. Can you tell us why or how physiotherapy has changed over the years? Because for a lot of physios that we meet, and that I've, due to my sports injuries and things that I've worked with, are very mechanistic in what it means to actually just have the machine or to do this. It's I don't know what to say. I don't want to knock it because it certainly helped me.
I understand.
But I'd love to know what your thoughts are then from a sports perspective as to how you can help an athlete even more.
Well, your guys' questions are almost like too good. Like it's hard because I don't know where to start. But I would say that it's there's always going to be a role of seeing the patient face to face, right? So I still see patients 1 day a week in clinic, and I work as a specialist physiotherapist giving non-surgical opinion. So I'm normally seeing either patients who don't want surgery, or they're seeing another physio and it's not worked, or they've seen another allied health or healthcare practitioner and it's not working. They want a different view, right? So when I see those patients in clinic, I'm considering what might not have been done. I'm looking at their exercise program, trying to think outside the box. I use hands-on techniques. I like getting my hands onto patients, trying different manipulative techniques. I like using clinical dry needling. I like using that. It's not all I do though, but I think it can be a powerful tool. In some patients, it's a breakthrough strategy. A lot of the electrical equipment I'm a bit skeptical on, as you're saying. I'm not so sure. I think maybe short term, and if the patients are really sore, we might have to default to that. But I'd like to try to get my hands on the patient at least for a few weeks if I'm seeing them in person. But then, as I said, I'm doing video calls most of the week, and so when I'm doing the video calls, I can't physically touch the patient, but I can get them to do self-treatments. And then you can have some patients who'll be in pain, will do a self-treatment, and then they get up and their pain's gone. They're on the other side of the world. So I think you can still use your reasoning processes to help the patients get out of a funk they might be in. And then any good therapist is trying to grade the person. You start at a safe level, right? You want to have them. You don't want to go too crazy and expose them to too much pain too soon. Some patients may be ready for that, but we tend to wrap them in cotton wool a bit and then just remove the cotton wool as we grade them back to harder and harder things like any other therapist would do. And then most of the time, it really depends on the case, right? So some cases are going to you can get them right quicker. ACL injuries are quite a long recovery. Even without surgery, we're talking 6 to 9 months, most patients. With surgery, it's longer, 9 to 12 months typically, or longer. So, yeah, you still have to build the relationship with the patient. There's going to be multiple follow-ups. So these are part of the facets that I consider when I'm looking at a case.
Can you explain an ACL? What does, for those people who don't know what ACL means?
An ACL. Okay. So an ACL is an anterior cruciate ligament. It's very synonymous with sporting injuries. It's often injured playing sports, like your classic change of direction sports. In New Zealand, Australia, we're talking rugby, soccer, netball. It connects the thigh bone to the shin bone. It stops the shin bone sliding forward and twisting in. So it's often injured when players or patients are stopping and they prop and twist and they'll feel their knee buckle. New Zealand, you see a lot of skiers will also have it injured, and obviously in the Northern Hemisphere more so. When their skis will stay bound, and then their knee will get stuck, and that can also cause it to. Patients will classically feel a pop, and they'll feel their knee swell up. It's essentially a severe sprain of their knee, and so it's in sporting culture, it's considered a massive deal to tear your ACL because the assumption is you need surgery to get back to sport.
There's a book out that I read probably 4 years ago, an Australian book, and it's called Hypocrisy.
Yes.
Written by an orthopedic surgeon.
Yes, it's a very good book.
Oh, well, can you talk about what they do? Is it the ACL that they're talking about in that surgery? What that knee surgery that they talk about?
Well, it's not. They're not talking about. I really like those two authors.
Yeah.
I probably align with a lot of their philosophy. You know, it's a bit sad. I'm friends with a lot of doctors, And there is a big question mark, and I guess that book raises it, that maybe very slowly, surreptitiously, the doctors have, some of them have inadvertently, they're not keeping their oath. They don't know, maybe they don't know, but this book just kind of raises that question. The Hippocratic Oath. So it's Hippocratic hypocrisy. And Ian Harris was the orthopedic surgeon who has gone on the record of abandoning a lot of the surgeries because of a lack of research evidence. And he's a very, very strong supporter of physiotherapy because he will have patients come to him saying, I want you to do the surgery. And he's like, I'm not going to do it because you need physiotherapy. I can't promise you'll be better. And so they talk, there's some pretty wild studies that have been done. And his other book is called Surgery, the Ultimate Placebo.
Oh, I haven't read that.
Which listeners could access, or they could get clips of it on YouTube where he talks about it. And so one of the most famous and somewhat controversial studies has shown that adjacent to the ACL, there's menisci. Menisci is two of them. Meniscus is one of them. And they're the shock absorbers of the knee. As we age, they degenerate. And sometimes you'll get tears in them as we get older. And so there's a common orthopedic procedure where through keyhole surgery, arthroscopy, the surgeon will go in and scrape away or remove part of the meniscus. In fact, I just wrote an article for the Australian Physio Association on this topic. I called it Keep Calm and Treat Your Meniscus Tear Without Surgery.
I like it.
Yeah. And I referenced that there's an author of psychology, his name's Daniel Kahneman, Professor Daniel Kahneman, and he has this book, this concept, think fast or think slow. Right. A lot of patients can be felt to, especially in that medical hierarchy, they can be felt to like think fast, act quick, take this pill. Whereas his philosophy and how I work with patients is I get them to slow down, stop, take a breath, and start asking questions. So whenever I do a second opinion, I'm thinking, I'll get the patients, can you just write out a list of questions that you want us to answer so they can take their time and think through it? What this study showed is when you scrape away or remove part of the meniscus, they had one group who had that done. They had another group who they went in but didn't remove any of their meniscus. These are people who had knee pain. They found that there was no differences between the groups. So basically, long-term, the patients who had the meniscus removed or the patients who went in, they just literally had stitches. And then the surgeon said to them the surgery was successful. And the patients improved. They got better, which shows that there is a placebo effect with the surgery. And it's actually quite wild when you see the interviews of the patients who had the placebo. They will say things like, it was the best thing I ever did. But this is where it takes a bit of a dark turn, because you realize that the patients, they looked at their x-rays. So the patients who had their meniscus removed had more arthritis for having had the surgery. So this is a big problem. So now, and this is not a one-off study, there's multiple studies that have shown the same thing. When you take away the meniscus, it actually accelerates arthritis in the knee. So not only are the patients not, and they had a third group who were getting physio, and they were the same. They also improved. So then the researchers said, start with physio, because you don't want to have a placebo surgery. You don't want to have a harmful surgery. You should just do rehab. But the problem is the healthcare models are set up that the patients are put in front of a surgeon quicker than they can access physio. So I see this a lot of the time. And so what you said with that case before, where the patient didn't really get to see me or my team, or that they went and they were in front of someone who said your only option is surgery. This is a very common scenario we see. So, yeah, it's hard because you're asking a question that's multi-layered and there's a lot to it. But these are some of this content and information is freely available for people. These are open access studies. But the research can take a long time to hit practice. So it can take like 10, 15, 20 years for the knowledge to get out there to the real world.
So multi-layered that I guess we could apply that also to the ability to plug one's AV into one's computer, just saying. But anyway,
yeah,
what I wanted
well,
to...
that's a bit harsh, but I don't agree with that comparison.
My husband played cricket for New Zealand for 10 years, Danny Morrison. He used to play, yeah, and he
fast bowler.
Yep. And one of the injuries, or the typical injuries of him, was spondylolisthesis. And
yes, well, I have a spondylolisthesis, and I can tell you the backstory if you want. I was a fast bowler myself. Yeah.
Stop.
Seriously, emerging, definitely not Danny Morrison level, but yeah, I fractured my back when I was a teen. Well, but it was missed.
Right. Well, he has also had stress fractures of the spine, never underwent surgery. His physio, Mark Plummer, I don't know if you know him, but he's also the physio now for the Auckland Blues. He was remarkable in the way that he went to China, learned acupressure, acupuncture, and did a lot of work with Danny. And Danny just felt that Mark helped him avoid surgery altogether because they wanted to get in there and do something. I don't know what you do for that condition. He did have a hernia. That's the only surgery he did end up happening. That was when we were over in England. But remarkably, considering the tension, the muscular skeletal ability to be a fast bowler, hurling that ball at 150 plus Ks an hour, rotation of the lower spine, the planting of that front foot into the ground. And Danny was short, really, for a fast bowler. Mm-hmm. So he would jump certainly higher than most in order to land and get that leverage from that bowling arm. When I look at his whole body, which I always looked at very interestedly, but I looked at the whole body, and this is what got me interested in nutrition, was how do I keep that body on the park, because that was our form of income. So I became part of his team. So it was massage. He would have all sorts of different people offering skills and insights and input. One particular guy rings in on his radio show one day and said the reason why New Zealand cricket's doing so bad, and in many ways, he was talking about functional movement. He said, we ought to take the New Zealand cricket team out and get them all pig hunting. So when they're out there pig hunting in the lower Southland, like a good hard Cantabrian man would do, then he could lift that pig up and trunch through all the mud and get back, and then maybe these guys would see the ball better. Now, he was really having a dig at our beautiful cricket team. But what's your thoughts around practical or like movement or exercises given that seem very mechanistic as opposed to functional kind of movements that encourages, whole movement, not just strengthening the quad or the bicep?
Yeah, very good question. So
we're quite good, aren't we, Kieran? I mean,
I reckon you guys are pretty good. You're almost too good.
Yeah. I mean, we'll take it. I mean, you know.
Well, I am just okay. Let's just address a few points here. I still support the Black Caps in cricket.
Good.
Now, you need to tell Danny, I'm a long-suffering Black Caps fan. He was my era growing up, watching him, and that's been a lot of pain until they won the 2019 Test Cricket World Champs. So that's like a lot of pain.
Try being on the inside, my friend.
I can imagine.
You know, just as a quick side note before you go there, he played in 48 Test matches for New Zealand over a period of time. They didn't play as much cricket as they do now, and they certainly weren't paid the way they are now.
Yeah.
But out of 48 Test matches, he was in 5 winning Test matches over his 10-year career. And take this one, Kieran, 3 of them were with Sir Richard Hadlee. That's how tough that era was. So you may continue, and I feel your pain.
Yeah.
Let's not talk on an Australian podcast about the underarm or the 1987 Test match when he was not given the LBW by an Australian umpire. But hey, I'm still not holding on to it.
The system's completely rigged. No, look, there's a lot of pain that you've brought up that I wasn't prepared for.
Well, maybe we can look it into the pain loop management, back to physio. But anyway, carry on about functional movement.
So I know what you're saying and I hear what you're saying and I actually fully agree with it. And in fact, there is very good research I've moved to Perth, so I grew up in Auckland, but I moved to Perth, right? And listeners can check out there's a very famous professor here in back pain, physiotherapist, who his name is Professor Peter O'Sullivan, also a New Zealander who moved to Perth. And he's created this method called the cognitive functional therapy. And so with people who have back pain that's not improving, they've done multiple clinical trials that's shown you can think different about your back, change how you move, and get rid of your pain. And it's quite fantastic. Like he's got this unbelievable clip on YouTube, which I show patients. It's something to the effect of back pain separating fact from fiction. And then if you put his name in there, you'll find it. And it's wild. So they show these patients who have been told you're going to die with backache. You can't lift, you can't ever run. Your back is screwed, basically. And then he takes them through this system of reframing their thinking, reframing how they move. And then it's quite a lot of the patients actually break down in tears when they watch it because they can connect with the human element to it. And so these people are, they're in like high amounts of pain. They're all stressed. You can see they're all guarded. They're like anxious. And then he shows how they move. And then he takes them through this, like again, it's open access journals. People can find it, cognitive functional therapy. The Restore trial is the most recent one. And then they do the follow-ups a year later and they interview them. And it's quite cool. They have the music's a bit somber at the start and then they have the music a bit more hopeful at the end. And the people are bending down, picking stuff up. They're like, I'm running 5Ks now 3 times a week. My back doesn't bother me. And you can actually see how people, given the wrong information, the trajectory kind of veers off this way. But then we don't just have to leave them there. You can actually turn these people around and kind of flip it back to see them take control. And so whether they need to lift pigs through walking around outside down the farms in New Zealand, but whether they need to do that, that's one thing. They can probably build towards that kind of stuff. But I think, yeah, classic gym training is like work biceps, work chest, work quads. Whereas a lot of when people are in pain, you have to get them to think about how they're moving and it does become more functional ultimately. You want to get the patients to, for sure you want them to have, like, it depends on the type of injury they've got, but a lot of these conditions, stress fractures, disc bulges, degenerative backs, osteoarthritic backs, slip vertebrae. If you look at the best of the best studies comparing, say, a lumbar fusion to doing an excellent rehab program, the patients are just as good. So then by default, the researchers will say, let's start with the least invasive first. And so a lot of these patients, you can turn them around and give them a really good outlook. Yeah, so what happened with Danny, I didn't know really his story, but we see that. Some people do need surgery, though. The hernias is a very good surgery for the big tears. And so the surgery options are always there. It's just that a lot of the time the patients can opt for this approach and do very well. Yeah.
Oh, I think you're making the point, though, you said it just before about athletes, that they're a commodity, really. And I say that with love, but they are, according to the
Sadly
selectors and things like that. So the sooner they get them back on the park, the sooner they're actually able to get their pound of flesh out of them again. So it is always driven by the quickest, most fastest. I don't think they use the word non-intrusive. It's just the quickest and fastest way to get them back on the park.
Yeah, like that's almost a whole nother discussion. And I do consult to some elite athletes and some high-profile clubs, and it's a different. You're right. They're like it's a time pressure, and it's a bit sad. I've heard some interviews on some, because I love my sports, right? That's how I grew up. I'm a very active person. My children are the same. It's like shooting basketball, kicking the footy. It's how I burn off energy. If I was left to my own devices, I'd probably watch sport most of the day. But I heard this one interview, and this journalist was talking about this player, and he said his market value. And it was like, I was like, oh, that's a bit sad. Like, and we'll see the players once they've finished their career. And that's where it's a bit harder when they're not, in the limelight, and maybe their bodies are a little worse for wear. But you're exactly right. The patients or the player are often like, we want to get them back by this time. What can we do? Whereas not always. Oftentimes, if we could spend longer or just wait and see, the wait and see approach is not really, wait, see, and rehab is not really that as common in elite sporting world. It's a bit more cutthroat.
Most definitely. Taking it away from the sportsman to the weekend warrior.
Yep.
I, in my 50s, started to get hip pain, really bad hip pain. So when I'd stand up, I thought I'd end up having a hip replacement. And being a nutritionist, I thought, well, I'm going to try diet. There's got to be something. So I eliminated everything but meat and veg from my diet, and then slowly brought it back in. And by the way, all the pain left while I was eliminating everything.
Yeah.
Then slowly brought it back in, and I figured out what my problem was. And so I stopped eating it. And so I never got that hip pain again. And then a couple of years ago, I got the hip pain again, had somebody look at it, didn't really help it. I was about to go on a 6-day hike on the overland track in Tasmania. I thought, oh, well, I'll just deal with it. I'll just have to deal with it. At the end of that 6 days, all pain was gone. I was back to normal, and it was almost like it adjusted me, that beautiful nature. And there's rocks, and there's tripping points, and there's roots, and it's not an easy track. It's up, down, over dale. You were never walking flat-footed. So I often think, food and functional movement as well, movement that we would have done before we started all these high elite sports, or before we just sat on our butt. Do you agree with me on that? Have you seen that before, that food makes a difference, as well as that movement where you go out into nature and you do what the body used to do?
Definitely. I think it's always, the patients often ask it, and I think it's always a factor for sure. I do see sometimes where, especially if they've got widespread pain, like if the patients are coming in with widespread pain, I'm thinking, is there some systemic inflammatory process going on here? And could that be, obviously, as you would know, you want to for sure target that before you would go on high dose pharmaceuticals, if possible, if that can be alleviated and it's linked to their pain. That's a great first port of call.
Yet we don't do it, do we? It's not the first port of call. And like, I was listening to you talking about all that, what they have to do in order to rehabilitate themselves. I watched, beautiful Dana, and she won't mind me saying her name. I've watched her go through this, and it's hard work. Just like it is hard work eliminating a food that you love, or it's hard work going on a 6-day hike. It's almost like the ones that will not opt for surgery, not always, because I know not always, but for those that that have been given this opportunity that you have given to one person I know, it's hard work. And not everybody wants to do hard work. They just want, just let me give a pill. Let me just take that surgery. I don't want to.
Yeah. There is like this kind of pill for every ill. Like that's kind of the mantra. And it's one of the big problems, I think, in westernized healthcare. I mean, the US is a prime example where it's out of control, and Australia's not far behind. And so it kind of pleads to the part of us that maybe doesn't want to take responsibility or does take hard work. I think like it's hard because I want to work with the patients, and a lot of these habits and a lot of these strategies, as you're saying, are going to take work, continued repetition, reframing how you think. In my field, it's discipline. You're going to have to do this exercise. I'll ask the patient straight up when they see me. I'll say, are you going to do these exercises? And sometimes I'll go a bit further and go, if 0 is a sloth, and 10 is an elite athlete, where would you put yourself on a sliding scale of doing these exercises? And the patients, if they go, I'm basically a sloth, then you got to go, well, how am I going to get you from a 2 to a 10? How can I get you from 5 to 8? So you just try to so in the master's degree, we focused a lot on that, like the psychology of pain and how do you get people to motivated to change, and it is possible. But some patients are just naturally. I'm actually, I exercise a lot, like probably 5 or 6 times a week, and have a rest days and stuff. But I wasn't naturally like that. It's taken years and years to do that, and it's particularly around strength training. It's not my natural. My wife's very self-disciplined with exercise, much more than me, and so I've had to grow into that. And some patients take time, but yeah, it's hard work. And yeah, I think it's a bit of a cop-out because some of the patients will think like, oh, I've got the surgery, I'm fine. And it's like, no, if you actually look at the studies, you need to do almost twice as much rehab post-surgery than you do if you don't have the surgery. So I think all this stuff, and this is why when I do sessions with patients, it's long. Like I like an hour with them because there's so much to cover. One of the professors at Curtin, who's also a specialist physio, she says when you're doing these initial consults with patients, it should feel like you kind of know them, like you've sat down and had a pub meal with them. You know them in the greater context of their life, and you can help to find their motivations to change and try to find the way in to get them back on the horse. But I think it takes it. So this is where when you have these healthcare models that are like quick solution, quick appointment, not much time to think, I think that's to the disadvantage of the patient long term.
And really that's the mechanistic view as opposed to the vitalistic or holistic view. And I just watched Dana, and like we had a flood, and her gym that she got herself organized, she knew the time she was going, she had to do it, I can't remember, once or twice a day, but she had it all organized, and then it flooded. And so she then had to, it's almost like she had to reframe everything to find another gym that was further away from her in order to do that. Now that to me, she has to have discipline. Yeah. She's got to be resilient. Yeah. So all of those things is what she had to have in order to get to where she is right now, as I read her text to you.
Yeah.
And I guess that's the question you've got to ask. Are you prepared to do it? Are you prepared to put the work in? Because that's what's got to have to be done.
Yeah. Yeah. And so like, I like to go there pretty soon in the conversation, like certainly in the first session. I'm asking them, like, this is going to be like, and with ACL non-surgical, it's still considered quite countercultural. So not only does the patient have to be self-disciplined, but a lot of the people they're interacting with, friends and family, they've got to have like almost a spiel of rebuttals or like ways to kind of go, well, have you read the studies that show that the ACL can heal? Do you know that the best studies show that surgery might be increasing arthritis? Like, so you have to, and it's difficult because then you get people just sharing their opinions. Like, what are you doing? You're crazy. Like, you're mad. Why don't you just go get the surgery? It's so quick. It's like a day procedure. So that's that social context as well. So for patients, I have a lot of empathy for them because it is. And then you can get these curveballs. A flood's a pretty big curveball, and it's going to, it's another bump in the road they've got to overcome. But yeah, I love working with the patients and seeing them overcome and seeing what's possible. Yeah, it's quite beautiful. Often it's quite incredible. Some of the changes you'll see, like they actually realize they're super strong, they're super resilient, and in a weird philosophical way, many of them actually end up better. Like they actually take control of their health. They kind of end up doing a strengthening program routinely that they weren't doing before. So it can actually turn around to become a positive, I think. But there's so many facets to it that it's hard.
You mentioned previously about pain. And for many people, I don't know what the statistics are, but I feel like it's pretty high that I may have read somewhere that 80% of people will suffer back pain at some point in their life.
Yeah.
My sister-in-law has also got a master's in sports physiotherapy. And when I hurt my back, and I worked 2 years with an osteopath and a chiropractor to avoid surgery.
Yeah.
Unfortunately, I didn't avoid it. It didn't go away. I found out also that I had spina bifida occult, and not that that had anything to do with it, apparently, but it was just my body. I had a ALIF procedure, anterior lumbar interbody fusion. Now, I did take my computer and all my books because I figured 5 nights in hospital was going to be like a little bit of a cleanse come time out. I wouldn't eat the hospital food, so I saw it as a wonderful opportunity for me to rehabilitate and to write my book. I have never been so jolted in all my life undergoing that surgery, and neither have I ever underestimated what my body would go through in order to endure it. And I'd worked hard for 2 years, so he seemed to think that I was in a really good, healthy position for the surgery. But beautiful Peter talked to me a little bit about chronic pain, which is one of her fascinations and interests. She talked a lot about the complex biopsychosocial neuroimmune approach. I think that's how she worded it.
Yep.
And I just would be interested to know from your perspective then, when we talk about acute and chronic pain, what would be, if someone's listening to this and they go, God, I've had back pain for years, or I've had knee pain for years, and I can't afford surgery, or I haven't done surgery. I'd love you to talk to us a little bit about the difference between acute and chronic pain, also looping in the pain, chronic pain explained. And I want to add to you post-surgery that I did do hypnotherapy, and we did what was called the pain paradigm, which then showed me how much unconsciously I could support myself, but I needed an external factor to help me know that. Anyway, go. Try that one.
Kim, how long is this podcast? How much longer have we got?
I know.
That was like a quadruple-barreled question.
I know, but I just want people to know that there's so many different approaches and that there is a real understanding of chronic pain and the psychology behind it.
That is, honestly, that's like a 2-day, I could give a 2-day answer to that question.
Right, let's go.
I don't have the time. but what, I think for listeners, if you've got chronic pain in a back, neck, shoulder, knee, elbow, hip, ankle, the common spots, right? That I would see. I wouldn't accept that you have to live like that. There often are fairly straightforward, scientific, evidence-based solutions that can work, that can turn your ship around. You don't, and sometimes surgery is that. You mentioned hip before, Cyndi. The total hip replacement surgery is the very good one. Like, that's probably my favorite, where I will give the patient 4 to 6 weeks of trying some different strategies with me. If it doesn't work, I'll pass them off to the surgeon who'll do that procedure. It's got a 95% success rate. But you absolutely, in a majority of cases, you can try these non-invasive, simple activities. It should be engaged with someone who's experienced and trained. Yeah, if you're seeing and especially if you're seeing a healthcare professional and it's not working, don't feel like it doesn't mean that non-surgical can't work. It just might mean that you need a different look. So that's what I do. That's what my company does. But it's just, I just have this philosophy. If I think you need surgery, I'll say. If I don't think you need surgery, I'll say. I'm very honest with the patients. And then if you can be straight with them and they'll go, look, I really appreciate your honesty. Like, I had one boy a couple of weeks ago, first session, I sent him straight for ACL surgery. It's because his tear type looked like it was never going to heal. In fact, he'd had an initial scan, then a follow-up scan 5 weeks later, it hadn't healed. So they needed me to tell them that. And so I think, but for most patients who are out there in the community, they should know that they have options and they don't just have to live in pain. Like, there's often options that are very good that can work.
I love this because it makes people feel back in control or feel like they've got hope. And hope, as you and I both know, is one of the most fundamental parts of healing or rehab from anything.
Yeah.
Pain is also very unique. It is, what I would consider level 8 pain would be someone else's level 6 or someone else's level 12 or whatever, above the 10 scale. How do you assess someone's level of pain? Is it just using that pain scale? And how do people actually really know and understand their levels of pain or how to manage it? We seem to be so afraid of pain, and yet it is a part of life in many ways.
It is, and it's often protective. So it's oftentimes protective. You know, you don't want to be trying to tell yourself that you've got high pain tolerance and just continuing to put your hand onto a hot plate and just like keep your hand there, because it's going to damage your hand. And if, you know, for someone like me who I was an emerging fast bowler, and this one day I broke down on the pitch because my back was in agony. I was 13. Young children will push through pain. And I had an X-ray which didn't show anything. 2 weeks later, I won champion boy, but I was in agony. And I just kept, and at night I was waking up with pain, but the X-ray was clear. So I just kept playing sport. I had an X-ray because my back was really sore when I was going through physiotherapy school, when people would push on my back. It was revealed that I had now complete stress fractures and a slip vertebrae. So I should have had a scan, but it was missed. And so pain can be helpful, and it can tell us that there's something wrong, because there may be things that need attention. You know, I've had a patient recently where we identified a stress fracture, and then you put that patient into like a 3-month relative rest. You can't just keep pounding the pavement to expect it's going to get better. So, but then sometimes, so the opposite to that is sometimes the pain system gets dysregulated. And so the body is hyperprotective unnecessarily. And then the patient's psychology can feed into that. So they're like moving in a way which is actually making their pain worse. So it's multifaceted. And then I will tell patients if they come in, because obviously the ones that come and see me, they've normally seen other practitioners. So they're typically like 3 months post, right? ACL's not, they're acute. They're a recent injury. But the other patients I see, if they're coming in and it's been more than, so basically if you've had pain for more than 6 weeks, I'd be stunned, and it's musculoskeletal, I'd be looking into seeing a practitioner, because you don't want it becoming chronic. By definition is more than 12 weeks or 3 months. So you don't want it to persist when it could be an easy solution.
You've made a really good point here about understanding us. My daughter was a top dancer, and she danced for 2 years with stress fractures of her back. And yet the coaches, the teachers were like, harden up, princess.
Yeah,
like
it's bad.
it was terrible. And it was only, and she had this pain, and this is what was so powerful, is she had this constant pain. They told her to harden up, to work harder. And for 2 years she did, and she danced in agony. But she went to a chiropractor, holistic integrative, beautiful, who's also a nutritionist and a biochemist, who looked at her. Taylor never mentioned her back pain. And this chiropractor said to her, you must have really bad back pain. Like, do you suffer with pain? And she said, no. And then she said, well, sort of. And then it was almost like this practitioner gave her permission to actually really feel the pain. And it was chronic and it was tough. And he was so brilliant as a physio, Kieran, you'll love it. He turned around to her and he said, Taylor, don't worry, but tell me this. You want to be a professional dancer for how long? And she said, for 10 more years. And he goes, that's fantastic. So that's 520 weeks. I'm asking you to rest for 20 weeks.
Yeah.
Can we do that? And that just for her, totally, and you said it before, reframed, acknowledged, and gave her credibility and confidence that she could heal this with the support of him.
Yeah.
Is that the role you love to see physiotherapists play?
I think it's in a lot of cases, yes. Like when I was postmasters being trained and mentored as a specialist physio, one of my mentors was a professor, and we had this case that was a difficult ankle, and ultimately she had a bone bruise. The girl was very despondent. Similar scenario to your daughter, not quite as bad, and the daughter was just really upset, and it was taking ages. And my mentor came in and assessed as a second opinion And he looked at the mum, looked at me, looked at the girl and said, "You want this fixed right now?" And she's like, "Yeah." And he goes, "That's not going to happen. It's going to be another 16 weeks." And she actually stopped crying. And she just goes, "That's good." So like she just needed to know that there was like a time frame prognosis, because like it is great to have hope, but people like an endpoint. They want to know that there's some measurable, factual time that they can stick by. And so, yeah, like one of the things I love doing with patients is giving them, hope is so vital. People need hope, especially in this day and age, but they need practical, they need like solutions. And so I think patients love to know what's wrong, what they're going to do, what the therapist is going to do, and then how long is it going to take. So I think that's a key part of what I like to do with the patients. Yeah.
So if somebody wants to come and see you, Kieran, where do they find you? Could you give us all your contact details, like your website, any socials that you might do, and even that Facebook page again? Will you please give us the name of that Facebook page again? I think these are really important for people who are looking at trying something before they go into surgery.
For sure. So if they're based in Perth, they can come see me at Live Well Physio and Hillary's. So that's I work still 1 day a week with patients face to face, but I wouldn't recommend traveling to Perth to come see me, because we can just do it over telehealth. And if you go to my website, globalspecialist.physio, and you'll see there's a section for patients that you can click on, and then you can contact me via email. My email I'm happy to give out is kieran@globalspecialistphysio.com. I have two main accounts that I post online. My Instagram account is more of my meme account, because I like having memes just to keep it lighthearted. When you're talking about pain all the time, it's not like, it's good to have some fun in there. So it's at global_specialist_physio. And then on LinkedIn, it's Dr. Kieran Richardson. The Facebook group is ACL plus meniscus tear recovery without surgery.
Which I just joined.
Did you? And you'll see it. There's patients from all over the world. It's quite unreal. Yeah. And you'll see a lot of the stuff that we're talking about. So we don't delete anyone's unless they're spamming. We just basically let people share their story, and we try to give them general advice. And you can see that it is a narrative that's changing. We didn't really get into the ACL topic a huge amount today. It was more everything else about health. But the ACL topic is very, very interesting. And it's moving quite rapidly, I would say. From like this, I've been a physio for 20 years, but I've been talking about ACL non-surgical for about 10. And it's rapidly changing. Like the landscape, the opportunities, the conferences we get invited to, the research has shifted, which is very, very good for patients.
Well, thank you on behalf of Kim and I for your time. And we have taken you over the time we said we would, but we really, really appreciate it. And especially it's still early. Well, it's not really that early in Perth, but it's earlier than what we are. We're at lunchtime, and yeah.
I just noticed one thing on your website, the initials FRAC.
Yes.
And I've been looking at that, and I wondered if that was just freaking really audibly challenged. I just wondered. I just wondered if you could share with us what actually FRAC means, really.
FRAC. It's a fellow at the Royal Australian College of Physios.
I don't know. I think freakingly, realistically, audibly challenged was quite good. You guys are
so cruel to me, eh? Don't stop beating down on me. I'm a humble Kiwi. I'm a humble Kiwi physio. Don't beat down on me.
It was a fast bowler.
Who was a fast bowler who got cut down in his prime.
Oh, I'm so sad. So did Danny, if it makes you feel any better.
That is a cool connection.
Oh, I tell you,
I've got to do another call in like 5 minutes.
I know, but I just wanted to say.
And I'm going to eat, which you guys probably won't. You probably want to approve of what I've got here. Was this all right?
No, we won't.
Was this help? Is this helpful for people?
Yes, you were very helpful. And I think what's so powerful is knowing that the stats are so high around pain, musculoskeletal injuries, and now the impact of how we think, feel, eat, and what we do around that, that there's options. I just wanted to finish off today by saying thank you for being the one that, went first and actually really did start to dive deeper on this and give us all more options around living our best life. So thank you, Kieran. As much as we've given you stick today, we have loved every minute of this conversation.
Oh, look, I think there's a bit of I don't know, awakening's maybe the wrong word, but it's like awake. I think people are becoming more awake, like they're questioning traditional healthcare views. Like, I thank God that I didn't do medicine. Part of, people have said, like, multiple people said you should have done medicine. And I'm like, no, I'll never do it now. I couldn't do it because there's so many things that we can help patients with that aren't drugs, surgeries, injections, scans, blood tests. So, like, I've converted. Like, I'll die on that hill. And I just think in nutrition, psychology, I think the nutritionists, the psychologists, the physios, the exercise physiologists, sports scientists, they need to believe in themselves more, not less, and not over stand up to doctors per se, but just like back themselves more. That's the thing that I get quite passionate about, and I try because half of what I do is teach physios, and I try to like fire them up to like get them to back themselves, because I could tell you guys some crazy stories, like just of doctors just treating me like shit. Like when you said that before about like having to, stepping out and talking about this stuff, like I've had like copped a lot of ridicule. And like even that meniscus paper I've just published, like on LinkedIn, the surgeons are firing up because they can't deal with it. Because it's just, I'm not trying to be a provocateur, but debatably they're harming patients. And they just don't, they get real arrogant and like, so that's the part of healthcare that it's a bit triggering for me.
I figured you had a thick skin, and I figured you also didn't care what people thought about what you said.
Now I don't.
Yeah,
now
I get that. Don't. You have to though, otherwise you wouldn't be speaking out. You wouldn't be on this podcast telling us what's happening. And like that surgeon that said to Dana, "Oh, you're never going to fix it. It's not going to work. That guy doesn't know what he's talking about." Like she came back distressed, and I went,
"What a prick!
Get him. Just
what
go."
A prick.
Yeah, I know. It makes you mad, doesn't it? It's like nutrition and mental health, nutrition and autoimmune disease, nutrition and sore hips. So, like I know that it's like I speak out about it, and you have to have a thick skin, and you have to go, well, I don't care what you think, but this is what I think. And
yeah, it's like it was good to talk about Ian Harris because he's been real. So like it's kind of like a whistleblower, right? Like you need people who are within that industry who call it out.
Yes.
Like it's hard. Like I'll be honest. Hopefully that came across. I send people for surgery because in many cases surgery is the best thing for them. But there's a lot of the time they don't need it, and sometimes the patients aren't awake. They need a surgeon to tell them that they don't need surgery. So in Perth, I've got I could tell you some crazy stories of them like yelling at me when I'm trying to give talks and like. So I've found surgeons who are more my view. And so I've got like a little posse of surgeons who support this type of, they're like more conservative. So it's you sort of need the same with doctors. You need like medical doctors who are going to go nutrition first. You sort of need allies. Like, that's how
that one line alone, Kieran, you're just now Cindy's new boy crush. That one, doctors need to look at nutrition first. Oh my gosh, she's just had major flow of oxytocin.
I don't like the objectification, all right? I don't like the.
We've had a ball with you today.
Oh,
we just want to say thank you for opening our eyes and hearts to the world of physio and musculoskeletal health. And you're amazing, and we've loved every moment.
We did.
Let me know when you guys share it because I'll definitely like to share it.
We will. Definitely.
Yeah.
Well, and Dana will too. Don't you worry.
Yeah. Well, I hope this has helped. I hope this will help the listeners. And yeah, man, what you guys are doing is good. We need it's Peter O'Sullivan, the guy I spoke about, the back pain guy.
Yeah.
He's a friend and supporter. There's this book called Tipping Point by Malcolm Gladwell. I don't know if you've read it or heard.
Yeah, I know Gladwell. I've read all his books. So
like, you just got to keep turning up the heat, like slowly but surely. And like, I started off pretty like, I got a bit triggered and I'll just like try to attack the surgeon. It doesn't really work. You've just got to keep doing podcasts, keep putting the stuff out there one by one, I think this stuff does work, and eventually it'll shift.
Keep manipulating their ego, not their muscles.
That's why I use memes, because like I actually did a talk where I used memes, and like they couldn't argue. They were like sitting there and they were like, what? Like they like, it's like goes past, because it goes to the heart of it and they can't really argue it. So yeah, like humor and stuff you've got to use, and yeah.
We've had a ball, and we've had a laugh, and we've also learnt a bit, and I'm still just so pleasured by the fact that you struggled as such an intellect to plug in your audio. I'm just saying, it was just magical to watch that.
If that's the thing that you take away from speaking with me, I'm highly offended.
We love you.
Thank you so much, Kieran.
All right, nice to see you guys.
Bye.
All right, bye.
Bye.
This has been a production of TheWellnessCouch.com. Check us out on Facebook and join in the conversation on Facebook.com/The Wellness Couch. Subscribe to each show on iTunes and check us out on Twitter. The Wellness Couch, streaming wellness into your lives.
Whilst the Wellness Couch presenter endeavor to provide accurate and helpful information to their listeners, these podcasts cannot take into account individual circumstances and are not intended to be a substitute for health and medical advice from a qualified health professional. You should always seek the advice of a qualified health professional before acting on any of the information provided by any of the Wellness Couch podcasts.